मंजुला रेडी ना चलेंगे?
We are live now, doctor.
Hello and welcome everyone. This is a live webinar by Glaucoma Society of India, and I'm Dr. Satyan, President Glaucoma Society of India. Today we have two masters. One is Dr. Sibal Bhatia. She doesn't need any introduction. And also we have Dr. Chandrima Pal. Both of them, they don't really need any introduction. We have two interesting topics for today. Dr. Sibal is going to talk about the neurodegeneration. Is it very interesting topic? Actually, it is completely an out-of-the-box topic. And Dr. Chandrima is just focusing on the MIGS, what is the current situation and what is that we can really learn and do things, and then we can understand and practice. So it is a very practical thing. But from Dr. Sibal's topic, we can understand what is really happening in glaucoma as a neurodegeneration. So without much delay, I would like to welcome Dr. Sibal Bhatia to start her first topic. Over to you, Dr. Sibal. Yes, Sibal, we can see your slide, but probably just full page. Can unmute your mic, Sibal.
Better now?
Yes.
Thank you so much, Dr.
We
Satyan.
can hear
As
you
always.
and we can see the slides as well.
Great. Thank you so much, Dr. Satyan, and thank you so much, GSI, for having me. It's such a pleasure to be part of all of our initiatives. It's a wonderful society to belong to and a privilege to be doing this with you. Before I begin, I want you to look at that number on the screen that took me 15 minutes to get just right on Canva, 21. For decades, that number has been the center of our universe in glaucoma. Our decisions, our targets, our anxieties, they all orbit around that single threshold. And today, I want to help you ask one question. Has our devotion to that number cost us something? I'm not here to dismiss IOP. I wouldn't be a glaucoma surgeon if I did. I'm here to suggest that glaucoma is a bigger story than we have been telling us ourselves so far. And that if we want to protect our patients over the long arc of their lifetimes, truly protect them, we need to start thinking differently. The IOP era, what we got right and what we got wrong, we have to start by honoring the IOP era because we should. The landmark RCTs, the OAT study, the EMGT, the CNTGS, these trials have saved millions of eyes. They give us a modifiable target at a time when we had almost nothing to do. That is not a small thing. But here is what it has cost us. We have begun equating a risk factor with the disease itself. We told patients, and perhaps ourselves as well, that if the pressure is controlled, the patient is fine. And in doing so, we stopped asking the harder questions. We ignored the patients who progressed despite controlled IOP. We starved neuroprotection research for decades because the pressure paradigm has left really no room for it. And perhaps most damagingly, we never told our patients that this is a degenerative disease. Both of these things can be true at once. IOP lowering was a triumph. Of course it is. And it has narrowed our thinking to something very, very limited. The prevalence and incidence of glaucoma-induced blindness and visual impairment have not been very different from those of the last century. And I speak as somebody who graduated at the turn of the century. The last 25 years haven't done much for glaucoma blindness, and that has to lead us to think that perhaps there is something that we haven't been paying attention to. Perhaps glaucoma is a brain disease. Just look at this pathway, the RGC cell body, the optic nerve axon, the optic chiasma, the lateral geniculate nucleus, and finally the visual cortex. So this is not just an eye disease. This is a brain disease that has begun in the eye. The RGC is lost silently before symptoms appear. Transsynaptic degeneration has been documented. Damage that spreads beyond the optic nerve all the way to the LGN and the visual cortex. MRI studies have shown measurable cortical atrophy. The sooner we frame it as a neurodegeneration, the sooner our patients benefit. And this is something that is genuinely when I was making this slide, I realized how dramatic this looks. It is a comparison table. Glaucoma versus Alzheimer's versus Parkinson's. 6 shared mechanisms. Neuroinflammation, all 3 of them. Protein misfolding in glaucoma, beta amyloid and tau deposits have been found in the RGCs. The same proteins, the same pathways. Synaptic loss, axonal degeneration, glial activation, check, check, check. There's a growing body of evidence that suggests that patients with Alzheimer's have a significantly higher prevalence of glaucoma and vice versa. This cannot just be a coincidentally overlapping disease. They are sharing biological machinery. In fact, glaucoma shares more with Alzheimer's than with any other eye disease. And ask any neurologist, they would be completely at home on that particular table because that's what they have been treating. And if we were to look at it as a clinical argument, there are 3 situations that the pressure paradigm just cannot explain. Normal tension glaucoma. There's progressive RGC loss, progressive visual field damage, pressures that never go up. Controlled IOP, lost vision. This is also something that we have known for the longest time. And if you are to think in terms of the number on the tonometer, you have to remember it is not the whole story. So many things, so many blind spots in IOP measurement itself. There's diurnal fluctuation, there's CSF pressure, its relationship to translaminar pressure gradient, biomechanics of the cribriform plate. IOP captures one variable in a very, very complex system. The number on the tonometer is not a lie. It is the only gauge we have. It is our thermometer. But it is not the entire story, and we cannot afford to treat glaucoma as though it is telling the entire story. And if I were to ask all of us this one question, how many of us have a patient with well-controlled IOPs who is still progressing? Good compliance, everything working, but still the patient progresses. That patient is telling us something. They are telling us that IOP control, while necessary, is not sufficient. They are telling us that something else is driving the neurodegeneration, something that we have not started treating yet. So whatever that patient is telling us, are we listening to it? Because if we do listen, the next question is, what do we do differently? So one more timeline that I thought would be an interesting look at long arc thinking and what it demands of us. Structural loss, let's say, starts at year 0. By years 3 to 5, we've lost more than 20% of RGCs. By years 5 to 7, we start to picking it up on ROCT. And somewhere around years 8 to 12, maybe even later, it shows up on our visual fields. And that's when we diagnose. Long arc thinking means we reject that delay. It means that we look at earlier biomarkers, structure before function, macular GCL changes that precede RNFL changes, octaflow reductions, and we need to move these to the front of our hierarchy. I'm not saying treat red-green disease. I am saying look at red-green with a little more respect. Longer follow-up horizons, not annual snapshots, but think of it as a 10-year disease arc. Glaucoma is not an acute disease. Our surveillance models need to reflect that. And neuroprotection targets beyond aqueous outflow, mitochondria, inflammaging, neuroinflammation, synaptic integrity. These are not future aspirations. The biology is already here. The trials are catching up. Long arc thinking is not pessimism. It is precision medicine. We are diagnosing now what the brain has already lost, and we need to make a difference on this one. Seeing the neurodegeneration, we have to address the imaging gap. OCT, RNFL, and macular GCL are the current standard, but remember, macular GCL might be the earliest structural biomarker. Octa is an emerging biomarker with peripapillary and macular flow reduction mirroring the neurodegeneration. The vascular component of glaucoma is now undeniable. Visual fields, of course, are the functional endpoints for staging, but it arrives much later. And when doing the visual field, you know how observer-dependent it is. The goal then is to catch neurodegeneration before the patient notices anything. And that glaucoma is a brain disease is something that we've been speaking of through the World Glaucoma Week. The brain projects what it doesn't see. And if you have a scotoma where this lady is crossing the road on the zebra crossing, you do not see a black spot there. It's not a positive scotoma. Instead, the brain fills up the spaces where the RGCs have been lost. And this is something that brings us to the agents that we have for neuroprotection. almost all of the drugs that we have available to us today, whether they are actually in clinical use or even in experimental or clinical trials, all of them have a mechanism of neuroprotection associated to them. Inflammaging is something that we need to remember. The hypoxia, the ischemia, the oxidative damage, the factors that influence remodeling, glial cell activation, the complement system activation, mitochondrial dysfunction, TNF alpha, inflammatory tuberculopathy is so important to remember when we talk of preservatives and long-term glaucoma drops use. And the frontier, what is here, what is promising, and what is noise, is also so critical to remember. And I know I sound theoretical, but this is something which is so promising in what it holds for us. Of course, neuroprotection by IOP lowering is something that we acknowledge. Brimonidine is a direct alpha-2 neuroprotection signal in RGCs. But the emerging and promising pathways, the BDNF pathway modulation, which is a survival signal for the RGC. The mitochondria target therapies. MitoQ is coenzyme Q specific to the mitochondria. And the SS131 peptide, they are mitochondrial targeted therapies for these actively metabolizing cells. Sigma-1 receptor agonists are actually proteins. They are chaperone proteins at the edge of the endoplasmic reticulum and the mitochondria that again help the cells metabolize. And senolytic agents, and they're used in cancer already, they clear the aged senescent RGC cells, which are the zombie cells, which are dying but haven't been cleared, and they continue to kill cells around them. All of these are actually being used in other drugs, in other diseases, and hold promise for glaucoma. The noise, the stuff that is not yet ready for use, is the stem cell intravitreal injections that a lot of us have been hearing about. That's premature clinical use. And most supplements marketed as eye neuroprotection are generally noise. The RGC is alive, and so is the window to protect it. So of these, what do we know is that the neurotrophin survival signaling is going into early clinical translation even for glaucoma. The mitochondrial reactive oxygen radical scavenging is preclinical, it's very robust evidence and clinical evidence in adjacent diseases. Again, the lamipritide is something that has been in clinical use. Multi-targeting with the sigma-1 agonists for the endoplasmic reticulum, the mitochondrial and BDNF peptides, they are clinical development stages in both HD and ALS, amyotrophic lateral sclerosis. Senolytics are again preclinical for glaucoma and early clinical stages in Alzheimer's. None of these, I would like to repeat, are approved for clinical use for glaucoma yet. The window is open, the biology is there, the trials are not here yet. The patient conversation that we are not having is again something that I wanted to talk about. My pressure is fine. I am fine. Drops are going to fix it, or MIGS are going to fix it. Mom's going to speak to us of MIGS now, which is the latest buzzword, and glaucoma and patients have started talking about MIGS. It won't get worse if I take my drops. Glaucoma is the same as an eye problem. Conversation to be had is that the IOP is one lever. It is not the disease. The eye pressure is cholesterol. It's not heart disease. Vision loss cannot be restored, and our aim is to protect what you have. And this is what you have to do to make sure you don't lose vision. And that has to be a conversation around discussing the allostatic load as well. High blood pressure, cholesterol, metabolic syndromes, all metabolic diseases, especially diabetes, anything that contributes to the oxidative stress on the RGCs. So a new clinical mindset where the old question we asked ourselves in the clinic was, is IOP controlled? The question has to be translated to, is this optic nerve protected enough? Has the field changed? How much structure and function is being lost this year? And what are the implications for the lifestyle of this patient? Is the patient compliant? Does the patient understand that they have a neurodegenerative disease that requires lifestyle modifications as well? And an annual review is not the same as a longitudinal neurodegenerative disease counseling and lifestyle advice. The goals for glaucomatologists have been very, very simple. We are preserving quality of life, vision-related quality of life, making sure that there are minimal side effects. The economics of the disease management has to be, put into play, as have the DALI and the QALY. The visual function has to be preserved. We preserve the visual field, hopefully prevent blindness. And our target IOP aims to balance the risks and benefits of glaucoma therapy and customize it to each patient. But what we forget that at the center of this entire conversation is one brilliant retinal ganglion cell. When we talk of patient centricity, we talk of patient autonomy, justice, we talk of non-maleficence and inviolate trust, because that is the ethics of glaucoma care. And we talk of individualized management because no particular patient behaves like any other. And when we talk of glaucoma, we must never forget that we are talking of an asymptomatic disease that now becomes symptomatic because we have started treatment for this particular patient. And it is therefore incumbent upon us to make sure that our therapy is both predictive, preventive, and personalized, individualized to the patient problem, phenotyping to whatever molecular phenotypes we know, patient stratification of risk, early and predictive diagnosis of disease, targeted prevention, personalized treatment plans, which has to include lifestyle advice as well as coping strategies. Which is why we need to remember, and instead, Dr. Satyan had asked us, just as we were beginning this thing, that we should remember to leave a take home message for each of our listeners. Instead, I'm going to leave you with a question. What would you do differently tomorrow in your clinic if you truly believed that your patient had a neurodegenerative disease? A lot of your conversation would have hinged around not just eye drops and eye pressure, but also around lifestyle and coping strategies for glaucoma. How should your home environment be for you to be safe, for you to prevent falls? Because remember, the most important comorbidity of glaucoma is not blindness. It is the fracture neck of femur because patients fall. That just as that lady was walking across the zebra crossing, if you remove a dining chair, the patient will forget that it will not know that there is no chair because the brain will fill in a chair and a patient sits on a non-existent chair. Which is why we need to remember that glaucoma is not just a pressure problem, it is neurons at risk. And our counseling of patients has to be around coping strategies as well. Thank you so much for giving me time to speak on a topic that is very off center and is perhaps not as clinically relevant as we would have wanted today's conversation to be. But it's a privilege to be here. Really grateful. Thank you very much.
Thank you, Dr. Shibal, for covering a topic which we happily brush under the carpet when we see patients, and your talk is an eye-opener. And I certainly completely subscribe to your advice that you have to look beyond IOP when you are seeing each and every patient. And I, for a example, is that I usually do advise patients on keeping a good lifestyle. The only problem is that, patients have been hearing this from all the doctors they go to. With the result, they believe that, doctors to ye bolte hi rahenge, and you do what you want. So that is a little problem how patients look at us. So you have to be innovative in how you give this message to the patients, and I completely agree on that. The next, only one question for you is that, do you think that in all patients we should be doing, because your point of your talk is that we tend to ignore, or we don't look at things we can't measure. As yet, we don't have techniques to measure the mitochondrial health or the neuronal degeneration rate, and therefore we are living in the bliss that it doesn't exist. So, right, we have to accept that today we can't measure it, but as you have enlightened us, we should not ignore it either. So, is there just 2 or 3 things that you can tell all our audience that when you see a patient, besides doing your target IOP stuff and looking at progression and structure function, for looking at the general health of the patient, is there some simple advice? Do you ask them to monitor their vitamin B12 levels and their D3 levels routinely and supplement it if required? And do they take some supplements other than that?
So I have started believing in niacinamide. So that's something I have reserved for my late stage glaucomas, 500 milligrams to start with, building up to 2 grams a day. But that's something I've started doing for the last couple of years. The jury is out there. I'm no one to comment on it because mine is a very small cohort, but I do believe in niacinamide. And of all the whatever vitamins that we have, I think niacinamide is the only sensible supplement to use. Coenzyme Q, if you can get, we don't have Mito Q available. So coenzyme Q also as a supplement is kind of like carpet bombing. It might just hit its target in the eye as well, but it can't harm you in any way. Short of that, ginkgo biloba as well as bilberry extract, from whatever limited evidence we have, because neuroprotection has not been something we have invested in as a scientific body. If glaucoma was one world, we haven't invested in neuroprotection enough. So the jury is again out there. If your patient is not on any kind of anticoagulants or warfarin analogs, then you might want to try them. I don't believe in them. But it's a Hail Mary. I mean, when you have nothing else to offer, then you say, okay, let's try this as well. The Aerods vitamins don't work for us. Those are not ours to prescribe, which is why you have these cocktail vitamins that are all over the place. I'm a very firm believer in metabolic syndromes. So I will harp on and on about blood sugar. I will harp on and on about thyroid control. I will talk about blood pressure, talk about cholesterol. And at the risk of being extra, I will also ask for vitamin D3 and B12. Because when this is more, like with early glaucomas, you try and have this conversation. But with late stage glaucomas, you have patients who are more receptive to this conversation.
Okay, great. I'm very happy to have you and to hear your thoughts and the evidence that you have shared and opened everybody's eyes. Thank you very much.
Thank you, sir.
And yeah, and we look forward to more in the future from you. Thank you. And now I would like to invite Dr. Chandrima Paul, who is front runner in the MIGS frontier today. And she is going to tell us about the status of MIGS in India today and how we are going to all look at it. Dr. Chandrima, please share your slides.
Thank you, Dr. Manish. Thank you, GSI, Dr. Satyan and Dr. Devan. Well, it's always an honor to be on any GSI program. Can you see my slides?
Yes, we can see them clear.
All right. So after that super illuminating talk by Dr. Shibal, we move on to something quite different, that is the minimally invasive glaucoma surgery, and the small surgery, but does have a big impact. And let's see how we are doing with it in our country. So I have no financial interest in any of these devices that I talk about. So if you look at the legacy of glaucoma treatment, it's primary open angle to angle closure disease almost 50-50, and it is the leading cause of irreversible blindness in India. So what happens is, on that note, just look at that pie chart where the maximum number of people with glaucoma are mild to moderate glaucoma. So this is a huge number. That's almost 77%. Refractory and advanced glaucoma are relatively less. So for this huge number, we need something. We generally leave it to the patient to treat themselves with medication. Some of them use it, some of them don't because they have no symptoms. But let's see what happens in the next few slides. So there's a paradigm shift for these kind of people who fall in this mild to moderate category of glaucoma. This is actually one of my favorite slides because this is a step ladder where once you diagnose glaucoma, you actually start on with medications and lasers, and now some of us do SLT. And then there's a huge gap. You leave the treatment to the patient, and then the patient comes back maybe one fine morning and says, I can't see. And then you see that, you have to go for a surgery. And then we move on to trabeculectomy and the rest of the surgeries as and when the situation might demand. So here actually comes in MIGS. This gap that we have between medications and surgical procedures, that's where actually we can do the minimally invasive glaucoma surgeries. So we all know the problems with medical management, compliance. Most of them don't use the drops, ocular surface disorders with all the drops that they use. Some of them have cardiorespiratory effects, poor quality of life because you're dependent on the clockwork of your drops, and then there are fluctuations in intraocular pressure over time. So let us have a look at this. So filtration surgery, actually, we try to reserve it for at least moderate to severe glaucoma, or sometimes, of course, we use tube shunts, etc. for refractory glaucoma. This area actually has no option for us to take the treatment in our hands. We just leave it to the patient with drops. So basically, if you do a surgical management during that period of mild to moderate glaucoma, you can stabilize the IOP. That can actually lead to less visual field loss. You don't have to bother about adherence and compliance. OSD is not there, and definitely that improves the quality of life. So looking at this timeline, MIGS actually started long back, but then for some or the other reason, it received FDA approval somewhere around, I think, 2012, and then we moved on from there. So adoption of MIGS in India is actually just quite new, about, say, 3,000 procedures, I think, across the country. So we've all seen that when we start a patient on medication, the first medication actually works really well. You can see that IOP drop that happens out here. It's quite huge, 5.7 millimeters of mercury, 6.9, 8.8, 9.5. That's a lot of drop in IOP after the first medication. But the moment you put the patient on second medication, the drop is actually not so much if you look at these studies. And the third and fourth medications have even less drops. So that is where the change is needed. The change is needed for compliance, better compliance and adherence, to keep intraocular pressure over 24 hours, 24/7. And then, of course, the histopathological changes that take place in the trabecular meshwork and outflow pathways, which lead to irreversible damage, actually to some extent also can be prevented. So that's the new paradigm that we are looking at today. We used to start with medication, but now we are asked to start with SLT, though I myself haven't started SLT yet for absolutely newly diagnosed glaucomas, but they have started in the West. Then you have additional medication. Here you have drug delivery, and this is where MIGS actually comes in. And then we go on to MIBS, and of course, after that, you still have the filtering surgeries and the rest of it. So why adopt MIGS? It has a very high safety profile because lower risk of hypotony, choroidals, hemorrhage, minimal disruption of the normal anatomy. It's an ab interno approach. You have direct visualization of the anatomical structures. IOP reduction is about 20%, though it's inferior to filtering surgeries, but then around 20% for mild to moderate glaucoma, I think, is quite good. And the compliance, of course, it's speedy recovery, and that makes it more acceptable to the patient. So if you look at this, the category of MIGS that we have out here, trabecular outflow, you have a lot of them out here, the iStent, the trabectum, the Kahoot dual blade, the Hydrus, which has just been launched. These, the ciliary outflow, the Cypress has been withdrawn, and we don't anymore have the iStent Supra. And then you have the subconjunctival outflow. We don't yet have the Zen. And then, of course, we have the endoscopic cytophotocoagulation, which actually reduces the aqueous humor production. So let us have a look at this, the MIGS revolution. And what we are going to concentrate on is actually this area. So this is what is important because the PESERFLO is yet to come to India, and the Express Shunt has been withdrawn. The Zen Gel is also yet to come to India. So let us concentrate on this, the Schrempf's canal outflow through the trabecular meshwork. So you have the trabectome, you have the Kahoot dual blade, you have the iStent, and then, of course, you have the Hydrus, the GAT, and our own thing, Dr. Devendra Maheshwari, who just actually launched the Dev dual hook. So we'll have a look at all of these one after the other and see how they do. So mild to moderate disease actually needs a trabecular bypass first. So we act to restore them and maintain the natural physiological outflow. The safety profile is actually comparable to cataract surgery alone, and maintaining the natural pathway can avoid the atrophy of the Schrempf's canal. So the simplest MIGS that one can do is this, where all you need to do is actually master your surgical gonioscopy. You can do that post your cataract surgeries in every single patient. And once you've mastered your surgical gonioscopy, you can actually bend a 27 gauge needle, bend it slightly less than 90 degrees, say about 85 to 87 degrees, and you can just strip the trabecular meshwork like it's done out here. And this actually would help a lot. And this is maybe the easiest and the most inexpensive MIGS that one can do. So that's just stripping the trabecular meshwork, and that helps in reduction of IOP. So the other one that we're going to talk about is gonioscopy-assisted transluminal trabeculotomy. That's the GAT. So it's a nasal goniotomy and then an ab interno trabeculotomy. So it's performed with cataract surgery or as a standalone procedure. In fact, all of them can be performed with cataract surgery or as standalone procedures. And they use a 250 micron eye-track microcatheter and advance it 360 degrees through the Schlemm's canal, shearing the trabecular meshwork for 360 degrees. And the outcomes, if you look at it, the outcomes are quite good. It decreases IOP quite well, about 6 to 8 millimeters, and for about 12 months, at 12 months. So the Kahoot dual blade. The Kahoot dual blade is actually a blade which has a couple of blades out here on the platform. And this is also a similar procedure where you can actually strip the trabecular meshwork and reduce the intraocular pressure. So it's about 20 to 30% IOP reduction. About 57.7% of patients with KDB and cataract surgery achieve a reduction of IOP of about 20% at 12 months, and the average medication is also reduced. This is our very own Dr. Devendra's Dev dual hook. This is what it looks like, the one on your left. I just used it last week. So this is a magnified form of it. It has a T-shaped hook here, and this is an arched plate on which the hook is there. And you need to strip on both sides. I have a video of this, but it's not really a good one. Not a very good capture, but you can see something. That's where it is. And you can see me stripping that, and there is quite a bit of bleeding there, which needs to be cleared up before you send the patient out to the OR. But that's pretty simple, and it also has good results. The patient is doing well. And to talk about the ECP, the endoscopic cytophotocoagulation. So this is a cyclodestructive procedure. And as I told you, it actually reduces the production of aqueous humor. And it also comes under MIGS. So coming to the eye stent. So the eye stent, as you know, is customized for a natural fit within the 20 microns of the canal space. It's made of a non-ferromagnetic titanium, heparin coated. So it is safe to remain in the body. And this is what the stent looks like. It comes in an injector system like this with the sleeve retraction button and the stent delivery button. I'll show you a video of this in a moment's time. And this is how the two stents are loaded. As of now, we have the iStent Inject W, which has 2 stents and it has 4 clicks. So if you miss a click, you can use another one. So 2 stents for 4 clicks is good enough. So who is actually a candidate for MIGS? Patients undergoing cataract surgery with mild to moderate glaucoma, primary open-angle glaucoma, can undergo MIGS, or it can be done as a standalone procedure. Cataract surgery patients who would benefit from better control of their intraocular pressure may be asked to reduce their medication if you do MIGS. Patients wanting to decrease IOP fluctuations associated with medication compliance, they can also be taken up for MIGS. Patients looking to avoid risks or more invasive procedures like trabeculectomy and the rest can be taken up for MIGS. And patients challenged in paying for medications, you can actually do the cheapest MIGS with almost no cost at all. And that actually lowers medication, the number of medications, and IOP too. So the diagnostic procedures that we do before MIGS is very simple. It's just like any other surgery. I'll just concentrate on the glaucoma workup. So the glaucoma workup, you'd obviously do a visual field and, examine the optic nerve head, do a pachymetry IOP. The important thing here is the gonioscopy. So the gonioscopy has to be done very well. You have to be sure that the angle is clearly open and you can see all the structures. A dilated fundus examination, of course, needs to be done. And after that, if the angle is open, you can see all the structures well, and there is no angle recession or any kind of other abnormalities, you can actually proceed with MIGS. So patient selection is actually very, very important. This is one of the take-home messages. Why mild to moderate glaucomas? Because aqueous drainage happens through the natural pathways, and IOP reduction is limited to the physiological levels only. 25 to 30% is the maximum reduction in most cases. That's the reason we ask for mild to moderate glaucoma. And in advanced long-standing cases, actually the collector channels might collapse. So a mix really might not work if you do it. The special considerations, of course, post-filtering surgery, you can consider it where there's conjunctival scarring and it's not possible to do anything else, scleral thinning or staphylomas, congenital and developmental glaucomas. And of course, in angle closure, you can do it after cataract surgery. When the angle opens up, then you can do it. Patient counseling is another huge take-home message. The patient has to be counseled very well to the extent that promise less, deliver more. So discuss with the patient why we are planning a glaucoma surgery. Explain to the patient about the various surgical treatment options which are available. Filtration surgery is usually required in advanced glaucoma, and you need to talk to the patient about it, that the patient might need a filtration surgery later on. The risks involved are also but higher in a filtration surgery that needs to be mentioned. And the viable option is MIGS for mild to moderate glaucoma, which will slow the progression, decrease the dependence on medications. Mind you, don't say you'll be off medications, improve the quality of life, and decrease the need for more riskier filtration surgery, perhaps in the future. So moving on to what we call interventional glaucoma today. So what capsular access is to phacoemulsification, direct gonioscopy is to MIGS. So gonioscopy is actually not the simple task of docking a surgical gonio lens on the corneal surface like we do femto and the other things, not at all. It is actually identifying the trabecular meshwork in the Schlemm's canal-based surgery, and you definitely need to identify the trabecular meshwork well. If required, you can use trypan blue, which is non-toxic to the trabecular meshwork, and you can see it diffusely stained. So what do we mean by en face? En face really means looking forward, and this is how we actually want to see it, the trabecular meshwork, the scleral spur, and the ciliary body. But normally we're actually accustomed to doing surgery, say phacoemulsification, TRAB, or any of the GDDs, we do them straight coaxial. If you do it straight coaxial, this is what you're going to see, and that doesn't help you with MIGS. The other perspective is this or this. Neither of them actually help you. So what you need to do is actually tilt the microscope 35 degrees towards the surgeon and tilt the head of the patient 20 degrees away from the surgeon. So this is how you're going to have an en face view, which you need to do any MIGS surgery. Talking about the gonioscope, this is our favorite Swan Jacob, but today we have the eye prism from Glucose, which is much more simple to use. You have the other gonioscope which can be put onto the microscope. You don't need to tilt the microscope, but it is expensive. But I think this is something which is going to take the market by storm, the Gonio Ready contact lens. So what does this do? I'll just show you a small video of this. This actually comes like this. All you need to do is place it on the cornea, and it has these plates, which I call pseudopodia, and you can actually make these flanges lie flat on the conjunctiva, place it well, and you really don't need your left hand for anything to do with the gonioscope. Your left hand is totally free. That makes the surgery much more easier, and then that's how you can do the surgery, and you can have a very clear picture of the trabecular meshwork as you see out there. So next comes the eye prism from Glucose. So I'll just show you a small video of this. It has two legs and it has a pod. You have to place the legs facing yourself. Once you've put a high molecular weight viscoelastic on the cornea, that's how you place it. And once you've placed this, that's how you get the view very clear.
That's the injecting system of the eye stent Inject W. The blue button is the sleeve retraction button, and the black one is the stent delivery button. To start the procedure, hold it in a pen-holding manner, keeping your index finger free. Place your index finger on the blue button and enter the anterior chamber of the eye. Once you've crossed the iris margin, retract the sleeve to keep the plunger ready for insertion. Now place your index finger on the black button, target the trabecular meshwork, make a dimple, and release the stent with a single click. Do not remove the pressure from the black button until you have withdrawn. Remove your finger, close the stent once again, and move to the second site about 2 clock hours away.
So those are the manufacturer's instructions, and this is the right place to implant the eye stent that you see out there. So this is a small video where you can see this is a normal implantation, which looks rather easy and can be, of course, done easily. But I will show you after that a couple of complications which can actually cause a lot of problems. So this is the trabecular meshwork. You see very clearly the plunger has been retracted, and then you implant the eye stent. Looks pretty simple and happens quite simply. You don't have to worry much. Then you move on to 2 clock hours away, and you can place the second stent. And once you've done that, like here, you can. Next, we move on to, let's have a look at this. So the side ports you do like you do in phaco. Here I've done a mistake. It should not bleed. It should be more corneal. So here I have actually gone and implanted the stent. And then actually, as you see, there are corneal folds. There was pressure on the cornea, and then it started bleeding, and I couldn't say anything. I closed the plunger. I brought everything back to normal, and I'm clearing out all the blood that is there in the anterior chamber. Then again, I go back and I put my viscoelastic, and that's where I implanted the stent. And then, of course, you clear it back again. So something like this can happen. Now look at this. So here I've implanted the stent, but see, it's popping out. It's not implanted properly. I saw it there, but I thought, let me implant the second stent. Then I'll come back to it and think what I can do about it. But by the time I went and implanted the second stent, this fell off. And then it was just a cat and mouse game. This rethreading of the stent is pretty difficult, so they need to actually come out with a kit for it. Finally, I rethreaded it. I entered again, and then I saw that there was a lot of bleeding there. Where should I implant it? That's the second stent. The first stent had fallen off, so I actually implanted it about 1.5 clock hours away. You can see those bubbles for rethreading. And that is it, basically. So these are the post-operative pictures, 3 weeks, 11 months, and 22 months. So now let us look at the Hydrus, which is the latest launch that we have. That's the Hydrus that you see. It can bend, is very flexible. So it's loaded into this, and that wheel that you see goes both ways. So when you implant it, you basically turn the wheel anti-clockwise and implant it. And if you think you want to retract it, you can again actually put that back and turn the wheel clockwise, and it'll again get retracted. So that's how it is, the Hydrus. So a little bit about the comparison of the different MIGS. So the iStent Inject, the Hydrus, and the KDB, this is a very independent and comparative data given by Arvo. So if you look at that, actually the iStent does pretty well compared to the Hydrus, the change in IOP, reduction in medication, and the KDB. This is a comparison between the KDB and the iStent, in which also the iStent did fairly much better than the KDB. This is the longest real-world study that they have, and it was a multicentric study, 16 studies over a period of 8 years, and there was quite good reduction, about 5 millimeters of mercury over 8 years. This is a very interesting study, the integrity study, done by none other than the god of MIGS, Aiki Ahmed, and he actually compared head-on the Hydrus and the iStent. So if you look at this in his comparison, the overall length of the iStent is about 360 microns as compared to the Hydrus, which is about 8,000 microns. The length residing in the AC, mind you, the anterior chamber, that's very important. The iStent is about 105 microns, whereas Hydrus is about 1,000 microns. This is another study where the Hydrus is in black and the iStent is in green. Everywhere the IOP reduction was better with the iStent. And this is another table which he had where the total number of eyes treatment failures were much less with iStent as compared with Hydrus. And the surgical complications also were much less with iStent than with Hydrus. And this is what he concluded very interestingly, that the study of current trabecular stent technologies produced high-quality evidence of the benefits of iStent Infinite and Hydrus, with iStent Infinite outperforming Hydrus when considering both effectiveness and surgical complications. So he clearly there actually thought the eye stent was better. We did a study which has just been accepted for publication in the IJO. It was sent almost a year back to IJO. So actually we have done many more eyes after that, but this is a study of about 28 eyes over 18 months, all pseudophakic eyes implanted post-cataract surgery or cataract surgery done earlier. We also found approximately about 6 millimeter of mercury reduction and approximately 57% of medicine reduction. So stents must be placed well, and surgeons should be trained in doing so. The stent should not be over-implanted or under-implanted, and it must be in the right place to achieve sufficient IOP control. And each mix has its benefits and drawbacks, so you need to decide which mix actually would be right for your patient. The pearls I'll leave you with are patient selection, mild to moderate glaucoma. You need to master surgical gonioscopy. It's not really another docking of the gonio lens on the cornea. Train yourself to follow the manufacturer's instructions if you're using any of the devices. Complications are generally low, but having said that, I would caution about that decimus detachment or implant dislodgement, as I showed you, or iridodialysis and hyphema, which can always occur, and handling of complications along with patient education on realistic goals are of paramount importance for a success story. And that has been our success story with the eye stent so far. Thank you very much for your attention.
Thank you, Dr. Chandrima, for your in-depth and very practical talk on MIGS and how to approach MIGS. And I'm sure that people are really motivated by listening to you. And you have given a very clear indications of when we should approach the MIGS and when not to think of MIGS and go for more filtering surgeries. So I think the session we need to now open for questions, and I would like to ask, our members who are online, Dr. Preeti, Dr. Devang, Dr. Ravindra. Please, Preeti, would you like to put some questions to Dr. Chandrima? Are you there, Preeti? Or Dr. Devang, if you are there?
Yes, at the outset, I think, Dr. Chandrama, it was a very wonderful presentation with all the videos that you had shown. Ma'am, like out of all the MIGS, which one would you prefer and why?
That's a very intelligent question. So if I go for a non-implant mix, then I would definitely prefer the Kahoot dual blade because it's very, very smooth. It's almost like, cutting the cake with a butter knife. And that is the one that I would prefer. And this is not out of the manufacturer's diary, but on the side that the Kahoot dual blade, actually, we do use it for at least 3 to 4 times after doing ETO. So it's not that expensive either. And if I go for the implants, I definitely go for the eye stent Inject W.
What is your take whether to go for implant, or how do you decide to go for either KDB or implant, or does the patient have a say for this?
The patient definitely has a say because I put my options in front of the patient. I tell the patient that this is what you're going to go through, and these are the implants which are available, and this is the cost of the implants. In West Bengal, that way we are lucky because the West Bengal health scheme actually supports eye stent. So patients who come with the West Bengal health scheme actually get it free. But otherwise, it's expensive, and so is the Hydrus, very expensive, unless the patient has an insurance. So many of them actually opt for the Kahoot dual blade because they say that, it's not that expensive and it's going to help me stop reduce my medications. But some of them also definitely go for the eye stent because they feel a stent, it's comparable to the heart stent and they feel that it's going to work better. So if they can afford it, they definitely go for the eye stent.
Ma'am, and in terms of clinical outcomes, do you think both are equivalent?
I think both are almost equivalent, but then we haven't yet done a study on the cohort as such. But we've done, this is the study which is going to get published, but this is almost a 1-year-old study. But we are actually improvising on this study, and by now we've done a lot of iStent inject Ws, and I think they have very good results. Actually, they are doing well. In fact, the first one I did, that was not a inject W, that was just the iStent inject way back in 2022 December. That's almost going to be 4 years, and that patient is still actually off medication, doing very well.
Okay, ma'am. Thank you, ma'am.
Thank you.
Dr. Ravindra, Dr. Preeti, are you there? So, Dr. Chandrima, I also have some very pertinent questions to put to you because you really have a lot of insight into the subject, and I think the audience will really benefit from that. You see that, do you stop blood thinners before you do these procedures?
Yes, absolutely. Absolutely. That's a very pertinent question,
because our cataract surgeries, if we are doing only cataract, we are not stopping blood thinners. But if we are going to do any mixed procedure, we are going to stop the blood. And,
absolutely.
and
Absolutely.
what kind of anesthesia do you use? Because all our cataracts are topical. So do
Yes,
you?
if I'm doing it post cataract surgery, I do it topical. But if I'm doing it as a standalone procedure, I always want the patient to be comfortable. So I always use a very small, about 3 cc of a single site block and do it.
Okay. Okay.
One thing I'd like to, yeah, go ahead with your
No,
question.
no, please, you can also give your clarity.
Just one thing I'd like to tell those who are starting MIGS that, you know, it's basically a company gimmick that they're targeting cataract surgeons and saying to do it post cataract surgery along with cataract surgery. But a couple of things. Number one is that when you're doing cataract surgery, you dilate the pupil. And however much you put pilocarpine post surgery, it really does not constrict as much as it would if you had not dilated it just then. That's number one. Number two is that however good a phacosurgeon you might be, there is some amount of corneal haze post phacosurgery. So those who are starting MIGS, I would say to do it as a standalone procedure, not after cataract surgery. Once you're confident doing it as a standalone procedure where you can clearly see the angle and do your implants or do your stripping, then only you can do it post cataract surgery.
That's a very good insight that you have shared, and I would tend to agree on that point which you said about the pupil and the cornea. They are both very valid points. And yeah, you may be an excellent surgeon, but the cornea may be not that good. And after you've done the surgery, it is going to show some amount of reaction. Even the epithelium, the epithelium also doesn't remain as good. Whereas if you're going to do a standalone, then you immediately go in. So before the epithelium gets any edema, you can finish your procedure. So your point is a very, very valid point, and I'm glad you raised it. The next query that I had is about the incidence of hyphemas. So my experience also with KDB has been that it doesn't cause that much of hyphemas. And iStents, so all the iStents I have done, I have not had a single patient who had even on the first day had any significant hyphema. But the other incisive trabecular procedures like GAT definitely have a much higher incidence of hyphemas in the early post-op. And there are reports of spontaneous hyphemas occurring during the first month, especially. So what is your experience and what advice do you give to surgeons on this point?
So I did have, in fact, I showed that case where I had a bad hyphema after the first eye stent. And you have to then actually, keep your nerves and bring your parameters right down, put your microscope back in the position and do your irrigation aspiration very well. And only when you're absolutely dead sure that there is no more active bleeding, then only go back to your MIGS. Again, put your microscope tilted and do your rest of your procedure if you haven't finished it. If it's happened post the surgery, then you need to clear it up very well before the patient is let out of the operation room. So that is one thing that is like absolutely one has to take very good care of it. Otherwise, you could land up in trouble, because if you're doing it on a pseudophakic eye or a phakic eye who has a 6/6 vision and the next day the vision is blurred, then you're in for serious trouble actually. So you really need to take care of that. GAT, I don't do at all. I tried it once and I'm not comfortable with it. I don't do it. I do a lot of bang. I do it with, as I showed you, my first one with a bent 27 gauge needle. I do that if required in really poor patients. I just do it post cataract surgery. I do KDBs, and I have used Devendra Maheshwari's hook as well, which also I thought was good. And that's it basically about the stripping. And about the stents, we just have two basically, the hydrous and the eye stent. So I'm actually more comfortable with the eye stent. The hydrous I haven't done because the company's dictum was to do 3 at one go, which I was not comfortable with because I didn't want to risk 3 of my patients on the first surgery day. So that's the reason I did not do the hydrous. So the eye stent actually, I think I'm very comfortable with, and it has given very good results over time, almost 3 years. Yeah.
Dr. Preeti, I just saw that you have come. You have any questions for Dr. Chandrima? Unmute yourself. Unmute yourself.
Yeah, during her presentation only she answered many of our questions. So whatever I had in mind have already been answered during her presentation. So nothing else really makes.
So I also had some other question, is that after you have done the procedure, whether it is a KDB, a bang or a stent, what is your follow-up protocol? What extra tests do you do and when on these patients?
All right. So just to start, immediate post-operative, I give an antibiotic steroid. I generally start it 4 times for 7 days and then 2 times for 7 days. I keep it on for about 15 days. And I generally give pilocarpine. I don't give any aqueous suppressants. So pilocarpine twice daily for the next maybe about 15 days or so. And then I take them off pilocarpine and the steroid and the antibiotic. And I see what the IOP is like. If the IOP is fine, I leave them on and then I call them after 6 weeks again. But if the IOP is high, then definitely you have to continue with the pilocarpine for at least a month or 6 weeks and then check the IOP again. So I generally call them about 24 hours after the surgery once. I call them again after a week once, and then after 6 weeks, I call them.
Do you do any anterior segment OCTs or do you do any other kind of gonioscopies at some intervals to check whether any synesthesia are developing, and especially the long term?
So basically, in normal cases, at the 7th day, I do a gonioscopy and I see that's a indirect gonioscopy at the slit lamp and I see the position of the stents. And if I'm satisfied, that's absolutely fine. But there was a case referred to us, which was done elsewhere, where actually they implanted the stent and after that, there was huge inflammation. So for that, actually, we did an anterior segment OCT and basically, I think along with the implant, a little bit of the iris got incarcerated. So that's the reason why the thing. So we had to actually remove the stent. We removed the stent because the iris was incarcerated and there was no way the inflammation could be controlled without removing it. So we removed the stent. And there was another one where they could not find the stent. So they had sent to see what's going on. So we could actually locate the stent with the anterior segment OCT. So these are, I think, basically two cases where the anterior segment OCT was of great help to us.
Iris incarceration is the first time I'm hearing. Wow, that's
yes. In fact, we've done a lot of them. Plus, people refer when they have any problem and all. This is the only case I think in the last 3 years where there was iris incarceration.
Dr. Chandrima, so if you're combining it with phaco, so would you still give pilocarpine or would you give tropicamide in your post-op?
No, I'll give pilocarpine. I give pilocarpine.
Prefer to give it BD or TDS?
No, BD. And actually, this case was done post-phaco, where the iris was incarcerated. So the pupil actually did not constrict properly. And the stent was implanted, and somehow the iris got pulled into it also. So that's the reason this happened. So I think for starters, and I think the person who did it was the first stent. So I think for starters, the best thing is to do in a pseudophakic eye or a phakic eye.
Yeah, so that is a very important tip, and I completely agree with that, what you said about the starting, because that is the first experience generally guides your this thing. And as you said, if your first experience isn't good, you're not going to be very motivated to follow up on that. It's a very common human psychology kind of thing. The other question I had is that when you are counseling patients for the surgery, especially those who are going in for the cataract with the MIGS procedure, and you tell them that, you know, either you can have the stent or you can have the KDB or you can have a bang, and financial considerations of costs is there. But do you tell them that the results are more or less the same, or do you tell them that one is a little better in the long run? Do you give them that point also, or you don't?
Yes, I do. I actually draw it out and explain to them, because I tell them that bang is more of a crude procedure. I will just be, cutting off this part of your of the structure, which will help to lower your pressure. But when I'm using an eye stent, it's a sophisticated procedure, like the stent in the heart. It's just a click. I would enter through a very small incision, and I would just put a click, and that stent there will help to drain your the fluid from inside your eye. So definitely, if you want a more like refined procedure, you need to go for an implant. But if you're okay with a little bit of stripping here and there, then you can go for this. And if you want a little bit more refined stripping, like I explained to them, like when you cut the cake with a butter knife and when you cut the cake with a vegetable knife, there's a difference between the two. So which one would you prefer? That's exactly how I do it, and I draw it out and show it to them. Yeah.
Good.
One
Dr. Shibal,
question, if I
do you
may.
have any questions for Dr. Chandrima?
One question, if I may.
Yeah, go ahead, Preeti.
You have used KDB and you have used Dr. Devender's hook also. Do you find a difference between the two in the ease of surgery, or how would you rate your experience using the two?
There are a couple of things in it. Number one is the entire, like the engineering of the KDB is very different from Devan's hook. It's very different. Like, if you see the KDB, the two blades are placed like, kind of facing each other on the platform, right? And you actually strip the trabecular meshwork in between those two blades. The trabecular meshwork gets in between those two blades, and that's how it is stripped. So that is the physics of the Kahoot dual blade. But the physics of Devendra's blade is completely different. Like it's a T-shaped kind of a thing over an arch. So the arch makes it a little easier to touch the trabecular meshwork. And then you've got to, he called it the hook. It's more like a blade. So it's like a very, very fine blade that you actually have to move on to your right and to your left. And the cutting is actually done by that hook, which is there. There are no, what should I say, blades or which actually go through the trabecular meshwork. This is just plain blade stripping of the trabecular meshwork, but the Kahoot is much more refined. The trabecular meshwork gets into that space, and the amount of trabecular meshwork that you strip is actually very, very symmetrical, and there will be no tags or anything like that. It's going to be a very, very, like, thin, uniform strip of trabecular meshwork that you're going to strip. So,
Got it. Thanks so much.
And we had a talk a couple of days ago where Dr. Tanuj Dada was talking about damaging the posterior wall or the wall of the Schlemm's canal, and that is the cause of failure. So you have any tip? Do you use a viscoelastic there, or do you use something to protect it when you do the stripping procedures?
yes, your globe has to be tight with viscoelastic. It really has to be tight, because if it's loose, there's every chance of what Dr. Dada said, that you can actually injure it. because it can collapse and you can injure it. But when it's tight, your globe is tight, and it's like when you say you have a very soft something, the whole thing can penetrate. But when you have something hard, then you can't penetrate the entire thing. It's like that. So you have to fill the globe tight with viscoelastic, and it definitely has to be a high molecular weight, non-dispersive viscoelastic, not viscose, which is dispersive. It has to be something where, like, the whole thing sticks to each other.
And also about the post-surgery, when you finish the surgery, the blanching. So do
Yes.
you check the blanching? Do you use trypan blue to check the flow, or do you just check blanching?
No, I just check blanching. I don't use trypan blue. I don't use it.
So thank you very much, Dr. Chandrima and Dr. Shibal, for a very, very informative and eye-opening kind of lecture. And I'm sure that you are going to be followed, because this is going to be loaded online and people can watch it later. And your tips would really guide a lot of people to better practice. So thank you very much for spending your time and participating in this. Thank you. And thank you all our members who also joined, Preeti and Devang and Ravindra, and thank you Devan also, for even though he is traveling, he still makes sure that he is there for GSI. Thank you very much, and look forward to the future. Thank you.
Thank you.
Thank you.
Good
Thank you
night.
very much. Good night. Good